Good evening, everyone, and welcome to our Community Health Forum for the City of Mesquite. My name is Cliff Kahili. I'm the city manager, and I want to thank everyone who is attending tonight. We are recording this, so it can be viewed at a later time. And tonight we have a very interesting panel on Suicide Prevention Awareness Month. And the idea is to talk about suicide prevention and suicide and try to alleviate some of the stigma behind it. So I would like to thank our panelists today. First, we have Shirley Weddle, who's a longtime resident of Mesquite. And after losing her only child, Matthew, to suicide in 2014, has become a community liaison for the city of Mesquite and an advocate for suicide prevention awareness. She is a tremendous supporter of the city and our community, and she is an advocate for our mental health efforts over the past year. So Shirley, thank you for being here.
Thank you.
We have Domingo Rodriguez, who is a 20-year retired Navy veteran and is a military veteran peer network and peer service coordinator for Metrocare services of Dallas County. And he is an instructor who has taught hundreds and constantly reaches out to the community to teach about military culture, suicide prevention, moral injury, and trauma-affected veterans. Skylar Woods Nunley is a licensed clinical social worker and is a coordinator for the mental health ministry at St. Luke's Community United Methodist Church located in East Dallas. The ministry's priority is twofold and includes eliminating the stigma attached to seeking mental health services and promoting mental wellness. And finally, we have Sharon Kim, who is the executive director at Mustard Seed Generation, a faith-based nonprofit organization that exists to spark dialogue around mental health in the Korean American community. She leads the bilingual and bicultural workshops and conferences for the Korean American parents, students, and community leaders. So as you can see, we've got a well-rounded panel with a lot of diverse backgrounds. So thank you all for being here tonight. We're going to start off with Shirley and to talk a little bit about the stigma attached to that affects a person's willingness to address mental health and suicide prevention. So Shirley, how have we had this continued existence of this stigma?
Well, Cliff, I think it's really important to understand the origin of the stigma when we talk about why it still persists. So in the past, people have tended to focus on mental illnesses instead of general brain health. Plus, they just don't have the knowledge that we have today. So this has led them to making unproven and incorrect claims as to why these conditions existed and how to treat them. Think about it. Untreated conditions often led to unexplained behaviors, which then caused fear, which then led to severe treatment of those individuals, which then led to stigma or shame around mental health and suicide. And then this misinformation got passed down from generation to generation because people didn't talk openly about it and they didn't have the knowledge to be able to prove it wrong. So lots of unjust and unfair laws, as well as practices in governments, healthcare institutions, and even in organized religions were created until researchers like Sigmund Freud at the beginning of the 20th century and organizations like Mental Health America brought about enough awareness and understanding to promote change. And often portrayals in movies and media today continue to promote that stigma. Some cultures still believe that getting help for a mental health condition is a sign of weakness. It is not a sign of weakness to get help for a medical issue. If we or a family member broke an arm or had cancer or diabetes or a heart condition, we'd be okay with going to the doctor or the hospital and getting help. So even the way we talk about suicide matters in regards to stigma. We need to practice saying died by suicide instead of committed suicide. The word committed has a negative connotation, and suicide is not a crime. We don't say we committed cancer or we committed a heart attack. So we need to get rid of the myths also surrounding suicide. For example, it is false, not true, that talking about suicide will lead to an encouraged suicide. So actually talking about suicide and asking the question, are you thinking about suicide, actually encourages people to talk about it because they know that you're willing to listen, and it releases them from that stigma. So it's really important for us to understand that mental health is brain health, which is physical health, to provide additional training to people, to work with media, to change perceptions, and to talk about mental health and brain health and suicide just like we would any other condition. We don't have to be a mental health professional in order to help people, like we don't have to be a cardiologist to perform CPR.
Well, Shirley, I know you've been on an interesting journey since the loss of Matthew in 2014, and it has resulted in a lot of education and advocacy, including the starting of a Rotary E-Club dedicated to mental awareness and mental wellness. And so, I think, I think you've become a great advocate because of what you've learned in that process. So last time we talked back in May, we kind of focused on teens and young people. Can you tell us about some of the other groups that are at greater risk of suicide?
Yes, Cliff, thanks for asking. Of course, the suicide still continues to be the second leading cause of death for young people ages 10 through 34. But veterans also have consistently higher risk of dying by suicide, as Domingo will address later. The Asian American and African American communities are also at higher risk due to a number of reasons that Skylar and Sharon will address. Other groups that are at higher risk of suicide include the LGBTQ community, retirees because of their loss of identity and social networks associated with their jobs. It's not always something that you think about. Those that have lost someone to suicide or have experienced severe life changes, maybe due to COVID, also are at higher risk. Even though the number of individuals that have died by suicide has decreased in the last couple of years, we still have lost over 44,000 people to suicide, which is about the number of people that would fill Globe Life Park in Arlington. And this reduction in number is not the whole story. Since COVID, there's been an increased number of deaths from overdoses and significantly higher numbers of individuals that are reporting mental health issues pre-COVID than in 2019. So higher numbers of individuals are seeking help, but they're facing barriers due to lack of accessibility and sometimes difficulty with insurance coverage. And also we're having some challenges with having enough mental health professionals available in Texas. And again, this is why it's so important for us to identify those at risk early and to provide proactive support. As I mentioned earlier, you don't have to be a mental health professional to help someone, just as you don't have to be a cardiologist to perform CPR.
So you mentioned recognizing some of the risk factors. What can you explain what those risk factors are and some of the warning signs of suicide, and what if we see these warning signs, what are we supposed to do, or what should we do to help people out?
As we're talking about this, I wanted to share the phone numbers for the National Suicide Prevention Lifeline. Because as we're talking about this topic, some people may feel that they need to talk with someone during this time, and I want you to have that information available. So if you could just take a picture of it, take a screenshot, or write this information down and put it in your phone, you want to keep that available because you never know when you might need it. So it's really important when we talk about risk factors, warning signs, and how to support someone in distress that we understand why people die by suicide. There's no single cause. It's caused by a combination of factors and stressors, which generate chemical interactions in the body, which exceed the current coping skills of an individual. And these factors can be influenced by sleep, diet, exercise, stress, and the chemicals and neurotransmitters in our body. The brain-body chemistry becomes out of balance. It's like we're having a brain attack as opposed to a heart attack. Dr. Thomas Joyner describes the person's feelings as they're having a sense of being a burden to others, or feeling a profound sense of loneliness, isolation, and alienation. Also having an acquired ability to inflict self-harm, which means that they have access to lethal means and no fear of death. So research shows that suicidal thoughts are often temporary And there's evidence that putting time and distance between a suicidal person and lethal means can save their lives. Risk factors are characteristic of conditions that can increase the chance that a person will die by suicide. They generally persist over a longer period of time, but understanding them is important, just like it's important to understand risk factors for heart disease. They're generally divided into three categories: health, historical, and environmental. Health factors include the parts of the brain, such as the frontal lobe and the amygdala and the temporal lobe, that are still developing through age 25. We expect our children to be adults at age 18, but their brains are still developing. The frontal lobe is where we have our decision-making occurring, and the amygdala impacts our emotions, our empathy, and our impulsivity, as well as initiating that fight, flight, or freeze response. It's also involved in post-traumatic stress. Think of these developmental changes in relation to the increased number of deaths by suicide in young people up to ages 34. Other mental and brain health conditions to be considered are anxiety disorders, depression, bipolar disorder, psychosis, which is really a symptom of bipolar disorder or schizophrenia, eating disorders, substance use disorders, and post-traumatic stress, which Domingo will talk a little bit more about. Other health conditions include chronic health conditions or pain, serious head injuries like traumatic brain injury or concussions due to sports injuries. We also need to consider other conditions that may result in depression that are treated differently, such as hypothyroidism. Depression is a symptom of hypothyroidism that we don't always think about. So maybe instead of taking an antidepressant, you take some sort of medication for your hypothyroidism. Neurotransmitters are also something to consider. Neurotransmitters are those body's chemical messengers that enable messages to travel between your neurons or your nerve cells and to other target cells. So they affect our behavior, our mood, and our ability to concentrate. And when they're interrupted, they can result in depression, anxiety, mood swings, aggression, tendency towards substance use dependency, appetite changes, and stress, which are all risk factors and warning signs of suicide. Two of the most common ones that we normally talk about are serotonin and dopamine. Historical risk factors include a family history of suicide, losing someone to suicide, previous suicide attempts, childhood abuse, and combat stress and moral injury, which Domingo will talk more about. This is especially prevalent with our military. Environmental risk factors include access to lethal means, various types of lethal means, exposure to another person's suicide, prolonged stress, and stressful life events such as the loss of a loved one, divorce, an unexpected job loss, financial issues, family health issues, especially now during this time of COVID, and retirement, as we mentioned earlier. Protective factors are some factors that reduce our risk and promote well-being. These are really being proactive because of these risk factors. It's really important for us to try to seek knowledge about brain health and suicide prevention and talk about it with our family and our friends. Talk about it like you would any type of ache and pain. We talk about how to, what the best solution is for our aching muscles and joints. Why can't we talk about what's going on in our brains? Engage in social interactions and connections, do brain exercises like we exercise our muscles, we want to exercise our brain. Things like doing puzzles, taking a different route when you drive to work or someplace, exercises different parts of your brain. Focusing your attention, doing things that are creative, helping others, volunteering, joining groups like at church or Rotary Club, which is a service group, and maybe personal interest groups. Getting the mental health care that you need, and strengthening your self-care. It's important to take your medication too if you've been prescribed medication. When we talk about self-care, we talk about having a healthy diet, exercising regularly, getting adequate sleep, which is a challenge for me, for those of you that have received emails from me late at night. Managing stress. There are multiple stress reduction plans that can be used that you can create together with other people, even as a group activity at work or in your family or at church. Taking brain breaks, like 3 to 5 minutes, 5 times a day, spending time in nature, connecting with family, meditating, using apps on your phone to help remind you of these things, and finding stress reduction plans. Also, it's important to participate in brain healthy programs, such as the Brain Health Project at the UT Dallas Center for Brain Health. So as we get older, it becomes especially important to continue to exercise our brains, as I mentioned, to keep them healthy. There's something important to know. Neuroplasticity is a term. It refers to the ability of our brains to build new neurons and connections so that we can recover from injuries, such as traumatic brain injury or concussions. And our brains can actually get better and stronger as we get older, even into our 80s and 90s. And because of this and all the additional work they're doing now with functional imaging studies, there's a lot of hope in the future that we'll be able to see depression and that sort of thing on objective imaging scans. We talk about warning signs. Warning signs are observable and signal suicide risk in the near future as opposed to risk factors, although some risk factors can turn into warning signs. So warning signs are generally categorized by talk, behavior, and mood. Talk signs include someone talking about ending their lives, whether they do it in a joking manner or not. Please take it seriously. Expressing their feelings of being a burden to others or feeling that they have no reason to live or purpose. Wanting relief from some sort of unbearable pain and feeling trapped or helpless. Atypical behavior includes trouble sleeping, maybe too much sleep, too little sleep, or you're having nightmares pretty regularly. You're withdrawing from activities that you normally enjoy. Now, sometimes there's reasons for these things. This is why it's so important to talk. Maybe there's a valid reason for that occurring, but you have to have that conversation to bring that out and to determine if there's an issue or not. If they isolate from family or friends, acting recklessly or impulsively, maybe they've abruptly discontinued their mental health medication, that's something to be concerned about. Looking online for ways to end their life or giving away prized possessions or excessive spending. Now, if they're going down to a smaller house and they have a reason for giving away their possessions, that's different than if they give them away when it's something that's really important to them and they wouldn't normally do that. Changes in mood, such as depression, anxiety, especially with social media now, embarrassment or humiliation is something they might have done where they feel really embarrassed by that and they just don't see a way out. It's important too to understand that sometimes, even though someone is having some difficulty, if they start feeling really in a good mood or they really seem that they're doing really well, you want to follow up on that too, because they may have devised a plan and maybe they're feeling some relief. So it's really important to have those conversations. So if you observe these warning signs, what can you do? You have to assume that you're the only person who's going to reach out. And you need to know what your resources are so that you can keep yourself and the person safe. Remember those suicide prevention hotline numbers that you can have available. You need to understand the perspective of the suicidal person. The crisis point's been reached. They're desperate to escape some sort of unbearable pain. They have tunnel vision. They don't see any other way out. Think about when you've gone through a night where you haven't had any sleep and you're trying to function the next day. You don't always respond the way you would normally respond. So it's really important for us to try to understand this, that they're not acting as they normally would. And because it's the brain that's being affected, they don't recognize that there's an issue. So it's really important for us to keep that in mind. And so how do you reach out? It's really important to listen in a calm manner, non-judgmentally, and engage the part of the person that wants to stay alive. Find their reason for living, not what you think it should be. Ask open-ended questions and repeat what you think they said or what you think you heard to help move the conversation along. Do not minimize their feelings. Don't try to fix things. Ask the question, and this is really hard, and you need to practice doing this. Are you thinking about suicide? Or are you thinking about ending your life? In fact, I recommend that you actually go to your mirror in your house and practice asking that question. Hearing it and thinking it is a lot different than actually saying it out loud. So if the answer is no, you listen to them and help connect them to their support network. And if the answer is yes, then stay with them and keep them safe. Unless you've had additional training, it's best to go ahead and call the suicide prevention hotline and let them guide you insofar as what to do. If you've been through additional training, then of course you can follow those steps. If at any time you feel that you're in danger or that person is in danger, then you could call 911. Again, I wanted to share the information for the National Suicide Prevention Lifeline for you to have that available.
Shirley, thank you so much for going through that. And again, I think I pick up, I know I've heard a little bit of this a couple of times, but every time I think I learn a little bit more about those warning signs and try to be a little bit more perceptive when I encounter somebody that looks like they might be having a crisis. So again, thank you for being part of our program tonight. And I'm sure there'll be questions here at the end for you. So I think we'll move on to Domingo. I know Shirley mentioned veterans are at increased risk. So can you expand upon that and why that is with veterans?
Sure. There's different aspects to, of course, being in the military. One of them is that you have this sense of purpose. You have a sense of mission, and as you're going through everything in life, everything is dependent upon the mission of your unit, which becomes your job, which is your mission, essentially. So in essence, your mission is your job, and your job is your life. It doesn't matter whether it's 2 a.m. or 4 a.m. or 7 a.m. and you just got off a mid-watch, which is an overnight watch. They call you, you're going in, and I remember before it was, hey, come in. Hey, I'm at the bar. Doesn't matter, find a way. Roger that, and you come in, and then here you come out. And so everything's entangled between life and mission and going through, and you come out to the civilian world, and the next thing you know, you have life in one hand and you have mission, or you have life in one hand, work in the other, and never the two are supposed to meet because they're supposed to be in balance, right? You're supposed to keep them separate and have that separation. But when you're used to, for whether it's 4 years or 20 years, having your life and your mission and your work combined to complete the mission, how do you change that mentality when you get out and you come out? It becomes something different. Your life no longer feels like it has a sense of purpose. It no longer feels like it's a sense of mission. And that's everyone's key looking for it. If you don't believe me, go to any local college that, somebody's trying to figure out their major, and you'll see exactly that whole sense of trying to figure out what they want to do in life and things like that. I also don't believe there's a midlife crisis. I think it's just them finally getting to a place where they can either start to find a mission or start to do what they wanted their life purpose to be. And everyone looks at them and says, you're a little cray-cray right now. In reality, that's not it. It's that just the fact that they're changing everything about themselves, and that's what they want to do. So that's what happens with the military, I believe.
Well, thank you for that. So moral injury and post-traumatic stress are mentioned as risk factors for suicide, and especially amongst veterans. So moral injury is a new term to me, and I think to probably others who are especially just exploring the concept of mental health. So can you explain a little bit more fully what moral injury is and how veterans can address it? And then, how can we support those that might be suffering from this or PTSD?
Right. Well, part of that loss of mission also comes the loss of everything else that comes with the aspect of that whole life. And two of the risk factors that you just mentioned, which are PTS and moral injury, really weigh heavily upon veterans. And I'm not saying all veterans have PTS or moral injury, but there are different aspects of it that could be affecting different service members' lives and also the lives of their family members. So moral injury it's basically the damage done to someone's conscious or moral compass when they either participate in or they witness or they fail to prevent something that transgresses their moral beliefs, their values, or their ethical codes of conduct that come from either their community, their organization, their religion, or even their tribe, or family units that can keep them from carrying on in their moral belief because of something that either they did, they didn't do, or they witnessed. So in the context of military service, it's the experience of war or any type of psychological, lasting emotional, social behavior, or social or spiritual act that impacts and violates that service member's moral code values and keeps them from finding that peace and finding that forgiveness in there. And whereas PTS is more based upon fear, moral injury is more based upon shame. And one of the aspects is that moral injury is not diagnosable. It is not in the book, so nobody can charge Medicare for it, and they can't charge for it. They can't diagnose it per se yet, but it is being worked on. I know the VA is working really hard on trying to come and find a way to be able to diagnose their service members and get them the help that they need.
Well, I would imagine veterans are exposed to a lot of different situations and all of those sort of things. So, and you said the VA is working on addressing moral injury. Is that something that you're seeing more for veterans as they leave service, or is it more of a service that kind of they have to experience and then the VA treats it?
So, like I said, it is not a diagnosable disorder yet. It's not in any of the diagnosis books or anything. They call it BVSM. So it's not in there. And right now it is kind of a new concept. I mean, it's been around since Vietnam. That's when it first was coined and coming through. But there are still people trying to write the story of moral injury, to tell exactly what it is, and some are mainly on that religious aspect that got to get right with God. There's something wrong there. You're not going to have moral injury if you have that. There are others that are it's you got to get right with yourself. You have to get that forgiveness in yourself, and so they're still trying to figure out, one, what it is and can be defined as, and two, how do we help the veterans and realize this too, it isn't just a veteran problem. There are certain aspects of it that are in the general public. Same thing, if you have a drug addict who is stealing from his grandparents, and he was taught to respect them and everything else, but he's stealing from his grandparents and he doesn't want to, but he has to, because he has to get that money to be able to get those drugs. That weighs heavily on people's hearts when they're doing things that they know are wrong, but they can't find a way to stop doing it.
I think that's a very good way to compare it to things that people who aren't veterans might be dealing with. Thanks for that comparison. So when you are dealing with a veteran that may be experiencing some of these issues, what are some of the methods that are used to address these?
So I've seen several different things that were kind of interesting in what the way that they were handled. I've seen one before where there was a church that had a service member come up in their uniform, and they introduced brother so and so to back to their congregation, and he was in his uniform and he left, and during the service he came back, and at some point everyone came up and they all put hands on him. Everyone that could reach him put a hand on him. If they couldn't reach him, they put a hand on the person that was touching him. But when he came back the second time, he was in civilian clothes, and the whole congregation welcomed him back. There's also another video out there of a tribe that did a ceremony where they had a Marine come out, and he went around the circle, and everyone that was there doing their dance, I can't remember what tribe it was, but they all gave him a piece of what they were wearing, and he would take it and give it to the person behind him, and they went in a circle. As they kept dancing later on, they all got back in the circle, and he came out wearing everything they had on and over his uniform. And as he walked by, they all stepped in behind him. And at the end of the dance, they welcomed back they said a tried and true warrior of their tribe. They welcomed him back to the people. So there's many different things. I've read things from Jack Canfield, who was talking about finding ways to forgive yourself, to find forgiveness in yourself, looking into yourself in the mirror and telling yourself that you forgive yourself for different things that you've done. That's a hard thing to do. I would challenge you to sit in the mirror and tell yourself that you forgive yourself. And an even harder one to do is to stand before a mirror tonight and tell yourself that you love yourself, that you not only forgive yourself, but you love yourself. And for some people, that's really hard to do. And you can tell a lot of what's going on by their language. You'll hear things like, if you really knew me, you wouldn't like me. If they really knew the way I was, the way I, the things that I've done, they wouldn't, love me at all. I'm going to hell. I'm going to, all these different things just because they think that what they've done is evil and they don't deserve to be forgiven.
Wow. That's great insight, and gives me a lot to think about. And you're exactly right. I think it's probably challenging for most people, not non-veterans or just just everyone in general, to do those things, to really do that self-assessment and self-validation to themselves. So
Cliff, I'll tell you the number one thing anyone can do: get educated on what moral injury is, look it up, try to find out for yourself. And then the loved one that you're afraid for, have them learn about moral injury, because the second they hear it, they'll know. They'll know. The Bright Divinity soul repair shop over at TCU has a saying that when you hear it, and there's a valid truth to that.
Well, great, and thank you for the homework as well. I think we'll all be going and looking in the mirror tonight. So, Skylar, let's move on to you. Start off by telling us a little bit about the ministry that you have, and kind of help, and then kind of talk about a little bit about the reasons behind some of the concerns that people might have and how to address them.
Okay. Well, I'm a member of the St. Louis Community United Methodist Church, and as a result of being a member, we had a committee who got together who was concerned about the mental health of our members of the church. And after doing some research, we determined that was a priority for our church, to help our members to become more familiar with what mental health illness was, to be more comfortable about talking about getting mental wellness. And so one of the things that we decided is that our community could no longer afford to ignore the spiritual, mental, and financial costs of lost productivity, lost potential, and loss of lives that were linked to mental health conditions. And so our goal was to do something about that. And so we developed this ministry, and the top goal is to counteract the stereotypes and the stigma that keeps our individuals from seeking treatment. And of course, we were looking at our members, but we are also aware of the community at large. And so we invite anybody in the community to participate in our mental health ministry activities. And one of the main things that we want to do, and this has been said by the two speakers before me, education is so important. So one of our goals is to educate our community about mental illness and get the facts about it, so that we can all reach the goal of mental wellness. They also talk about some stigma that is related to getting mental health services. And one of the things that we found out is that people were dependent on the church to just help with their concerns. And so, we are a praying church, but we know that it takes more than prayer. That's only that supplements getting mental health treatment. It's supplements going to a psychiatrist, a therapist. And so we wanted people to feel, to get the education that we strongly believe in our faith. We strongly believe in prayer, but we also know that this is a condition just like a medical condition that needs to be treated. it needs attention. And so that's one of the things that we focus on. And what we found out is that people were fearful or shameful about being labeled as crazy. And so we had workshops saying one of our particular, which was very interesting and highly attended, is like, we have to stop saying crazy. And so, that to eliminate some of the stigma that's attached to mental health. So we had different mental health providers, advocates to talk about that topic, to just really educate our members about mental health. Also, in addition to the stigma, we knew there were some other basic, other real issues that we had to address too. We know there's a shortage of minority mental health providers, and so we were trying to make sure that they are aware of providers in general, but many of our members and what we found in our community felt more comfortable going to someone who understands their culture. And so we were trying to make sure we have providers from a diverse list of providers, a diverse list of speakers who would come and talk to our members, as well as community, so that we can start getting our members familiar with mental health providers, also to get familiar with what are some of the signs and symptoms of a mental health condition, when is a good time to go ahead and intervene. Sometimes people have waited so long that it's become severe, and it could have been, if they had an intervention earlier, it may not have gotten to that point. So our goal is really to try to educate our members about mental health. Other things that we also found out is that people may have had insurance to cover, therapy sessions, but the co-payment was still a financial challenge, and so, we try to we try to work with our team so that we can make sure there's a list of resources. And we're happy to know about Mesquite being, offering, counseling to their citizens. We were really excited about that. And so, of course, we're adding that to our resource list. But the main thing is that we want to encourage people of faith to see mental illness as a treatable condition, just like any other illness. And we want to put out the message that God wants you to be free from your suffering, and there are treatments available to help you with that.
Skylar, I think that's, we kind of talked about education, but I think also just being able to dialogue about it with other people is an essential component of that, relieving that stigma. So when we had our forum in May, we did talk about depression and anxiety, but we didn't have enough time to talk about bipolar disorder or schizophrenia.
Okay.
Can you help us understand these two conditions a little bit more fully, and when individuals experience these symptoms?
I sure can. So bipolar and schizophrenia, those are mental health conditions, and it's considered under the serious mental illness category. And bipolar disorder is a mental illness that causes dramatic shifts in a person's mood, energy, and ability to think clearly. People with bipolar experience high and low moods known as mania and depression. And this, everybody experiences some ups and downs, but these are clinical changes, clinical marked differences of your ups and downs. And I do know just from being exposed to the young adults, sometimes they use their term loosely, you're being bipolar, and so we just want to make sure that people understand that is the clinical diagnosis, that is a serious diagnosis. And when people are experiencing those symptoms, we strongly recommend treatment, because we know that any serious diagnosis like that can lead to suicide. And so it's important to have an intervention at an early stage. But bipolar, usually the age of the onset, the average age of onset is about 25 years old, but it can occur in teens, and it's not as common in childhood. And when we go to a serious diagnosis like that, it's usually we see it rising around 18 years old or older. And so the thing about the bipolar is that it affects men and women equally, and about 2%, 2.8% of the U.S. population is diagnosed with bipolar disorder, and 83% are classified as severe. And so it's very important that it's treated. And the good news about it, it can be treated. And what is recommended to treat by bipolar is psychotherapy, counseling, medications, a healthy lifestyle, a regular schedule, and early identification of the symptoms, which helps people to live, with this diagnosis. There is not a single cause of bipolar disorder. The chances of developing bipolar disorder increase if the child's parents or siblings have been diagnosed with bipolar disorder. There are different types of bipolar disorder. Bipolar 1 is the illness which people experience one or more episodes of mania. And most people diagnosed with bipolar 1 would have episodes of both mania and depression, although an episode of depression is not necessary for a diagnosis. To be diagnosed with bipolar 1, a person's manic episodes must last at least 7 days or be so severe that hospitalization is required. There's bipolar 2. It's a subset of bipolar disorder, which people experience depressive episodes shifting back and forth with hypomanic episodes, but never a full manic episode. Then you have the cyclothymic disorder, which is a chronically unstable mood state in which people experience hypomania and mild depression for at least 2 years. People with this diagnosis may have brief periods of normal mood, but there are periods that last less than 8 weeks. Okay, schizophrenia. It is a serious mental illness that interferes with a person's ability to think clearly, manage emotions, make decisions, and relate to others. It is a complex, long-term medical illness. It is difficult. The exact prevalence of schizophrenia is difficult to measure, but estimates range that about 1.25% to 0.64% of the U.S. adults. Okay, some of the symptoms with schizophrenia include there may be some hallucinations. This includes a person hearing voices, seeing things, or smelling things others can't perceive. It is very real to the person experiencing it, and it may be very confusing for a loved one to witness. The voices in the hallucination can be critical or threatening. Voices may involve people that are known or unknown to the person hearing them. Delusions, they're false beliefs that don't change even when the person who holds them is presented with new ideas or facts. Persons who have delusions also have problems concentrating, confused thinking, or the sense that their thoughts are blocked. And I'm going to give you an example of a delusional episode that I had recently with a client. There's this 54-year-old woman. She was very sure that her husband had invited her to go to the Candyman movie theater. She felt they were having some difficulties in their marriage, and so she said that he had set it up for them to go to see the Candyman movie. And once she got into the movie, he had arranged for her to be kidnapped and taken to the dark world. And so and then in the dark world, she was there for them to do anything. She was, at their demand, they can do anything with her. And so so some of the things we do know, there's a movie Candyman, and so some of the things they have some facts. And so if you're not really if you're not really been educated or trained on some things, you may really believe, you may begin to believe some of the things that an individual may say. And so one of the things that, and I was going to talk about that more, you can't say, well, you're being unreasonable. That's not going to happen. The best thing that you need to do is, and she was really afraid. She was really fearful. So you just have to deal with the emotion. You sound really afraid about that, and scared that you decided not to go. To the movie theater. And so that's one of the things that having that experience education will help you deal with some of those symptoms. Another symptom, negative symptoms, and that includes people being emotionally flat, speaking in a dull, disconnected way. People also may be unable to start or follow through with any activities. They show little interest in life. And one of the things with a negative symptom is that people begin to not take care of their personal grooming. So when you see someone who totally looks disorganized, not groomed well, or inappropriately groomed, those also may be an indication that that person needs some mental health intervention. Also, they may have disorganized thinking. They may have lack of insight. This person is unaware. It's to the point that their behavior is bizarre, but they have no insight about that bizarre behavior. And so those are another sign that mental health intervention needs to be done. The one thing to know, the good news is that both these diagnoses can be treated. You just need to treat them as, work with the individual, work with the family member to, because many times when someone has experienced these conditions, the brain cannot rationalize that they need help, and so it can be very challenging. And so the thing is to just work with that individual. I'm going back to that example that I gave you. One good thing about it, there was the lady. I said, "Well, you seem stressed." I said, how would you feel about getting a mental health assessment? And the good thing about it, she agreed to it. But we know there are many cases that they don't agree to it, and you have to take it up a higher level. And so my passion is to try to educate people about the symptoms of mental health, so that it doesn't go to that severe advanced stage. And there is hope, and that's another component of our church. We want to give people hope, that things can change and things will be better.
Skylar, thank you for that, because it's those, I think, we tend to generalize and we try to lump things in, and we try to, a lot of people do misuse terms, and so I think having those details on the differences and really just how to that there's an urgency to get help for somebody because of the injury that they could cause. So,
Right, yeah.
Thank you for sharing that. And I want to make sure we get to Sharon tonight. So Sharon, you have an outreach to groups around the Metroplex and to help them understand and be sensitive to the Asian American culture in relation to mental health and suicide prevention. So, and as well to supporting people who have experienced suicide loss. So, to avoid any misunderstandings, can you share how you define Asian Americans when talking about culture and the differences in generational thought regarding mental health and suicide?
Sure. So I'm a visual learner, so I had to put together a slide. But when I talk about Asian Americans or Asian American Pacific Islanders, we're talking about people who come from or have origins in countries in East Asia, Southeast Asia, or the Indian subcontinent. And there are about 20 million Asian Americans living in the US. 1.5 million of those live in Texas alone. And it's very easy to think that this Asian American group is one monolith, but it's actually a very diverse group of people with unique histories, cultures, and languages. And so even when I work at Mustard Seed Generation, we work with Korean Americans. We find that even Korean Americans, they're such a diverse group of people. And so I think it's very important for us to understand the background, the culture of where somebody's coming from in order to help them better.
So from a history and culture perspective, how do Asian Americans view mental health and suicide? And are the stigmas different, or are they similar to what what's out there? Is there a difference?
Yeah, great question. I actually loved hearing what Skylar was talking about, because I saw a lot of similarities across different, African American and Asian American populations. Before I get into that, I wanted to share some of the mental health statistics. So suicide was the leading cause of death for Asian Americans ages 15 to 24. Asian Americans are 3 times less likely to seek professional mental health help than compared to white counterparts. And instead, what they do is they tend to seek emotional support from their friends, peers, families, and faith leaders. And some of the, you alluded to that in your question, Cliff, but some of the barriers to that is the cultural stigma. So cultural stigma, including the cultural values of Asian American communities, includes such as, filial piety, where you're supposed to honor your family above yourself. And so for instance, acknowledging that I have a mental health need or a mental illness is actually bringing shame to the family, because mental illness is considered a sign of weakness, and you don't want to bring shame to your family. And so it's really hard for people to, open up about their mental health needs. And there might be also financial constraints. I think this was talked about by other speakers as well, where they might live in poverty, or they might not have the health insurance to cover their costs. But also, something that's specific to, or might be more specific to, the Asian American community is that there are limited bilingual resources and a shortage of culturally sensitive or culturally competent care providers. And by that, I mean that 40 to 50% of Asian Americans don't have access to mental health because of their limited English abilities. And so instead, we think that we can, they have interpreters, they can just go to, a place, but it's really hard if your mother tongue isn't English to actually go to a place. And there's a shortage of interpreters, first of all. And there's also, that not only prevents them from actually reaching out for help, but also continuing help and continuing treatment. It's also very hard when people don't feel like the mental health provider is culturally sensitive or knows where they're coming from.
So you mentioned that people tend to seek out help from their family members or faith leaders, and instead of professionals. So I assume that that creates more of a problem, because that sensitivity and not wanting to appear weak and all of that. So is that any ideas how people can get over that?
Yeah, I mean, Cliff, you got that. You got that right. Where there's a lack of family and social support because there's that cultural stigma. And so if I reach out for help from my friend and they come from a background where mental health is stigmatized, they might say snap out of it, or you got this, or it's going to be okay, and be dismissive about it. I think one way that you could go about that is to really find maybe sources or culturally sensitive sources. There's more awareness about diversity and culturally sensitive resources out there for Asian Americans or for other groups as well. And so I think looking out for those, as well as what we do at Mesquite Generation, and I'm getting sort of into what we do, but we also train church leaders and faith leaders because of that, because people tend to go to faith leaders more. And so we train them so that they can have mental health tools and resources to address mental health needs appropriately.
Well, tell us a little bit about more about what your organization is doing to kind of improve this outreach and improve the care for Asian American individuals.
Sure. So at Mesquite Generation, we work with Korean Americans, and we spark dialogue around mental health in the Korean American community. And this is why. Korean Americans, 1 out of 3 Korean Americans live with depression, which is higher than other Asian subgroups. Suicide was also the 7th leading cause. And elderly people, as well as adolescents, also are at risk groups. They have significantly higher rates of suicide compared to other Asian Americans. And yet, as I mentioned before, just like other Asian Americans, they're less likely to seek professional mental health care. And so what we do at Mustard Seed Generation is we educate families. First of all, we bring parents and children together to talk about immigrant mental health, Korean American mental health, to give them tools to know what to do, to communicate better with each other, to be able to deal with generational issues and conflicts, cultural conflicts inside the house, inside the home. The other thing that we do is we, as I mentioned before, is we equip church leaders with mental health tools. And so we train them, we tell them, hey, this is what you do when there's a mental health crisis. Sort of what Shirley talked about today. And that's exactly what we do with our church leaders. And then the last thing is we want to address this holistically. So we don't want to just do families and church leaders, but we also feel a need for Korean American mental health professionals, because they all, as many other mental health professionals, they all work in silos, and they don't realize that there is a good community of Korean American mental health professionals out there that can work together. And so what we do is we host national summits, which our next national summit is actually happening next week. We host national summits. We bring Korean American mental health professionals together so that we can strategically collaborate and raise national awareness about mental health in the Korean American community. That's something that we do. Is we want to, like Skylar said, we want to bring hope. We want to bring reconciliation and healing into into our Korean American and Asian American communities.
Thank you for sharing that. And I think that's a unique perspective from the cultural side of it. And I would assume that as diverse of a community that we have in North Texas and throughout the United States, that we run into these cultural issues in all cultures. And so I think understanding that there are nuances and different perspectives is really enlightening, especially for this conversation tonight. So thank you. And I know we've talked a lot about different programs and resources. So Shirley, I know you've been collecting a lot of information on resources, and so do you mind sharing a little bit more of those? I assume you have a slide that will kind of give us a really good list.
Yes, I'd be glad to do that. Thank you for asking. So I have two slides for you. One is in relation to training that we offer for the community. As we mentioned earlier, we started a new suicide prevention brain health Rotary E-Club, and one of our goals is to be able to provide education for communities. And a lot of our members are involved with other groups. So we have different presentations that we make available, like Talk Saves Lives, mental health first aid courses for youth, adult, and teens, applied suicide intervention skills training, which Domingo and his group we're helping to provide and support this week. In fact, we're having one of those trainings in Mesquite on Thursday and Friday. So we're just so glad that we're able to provide that. SAVE, which is a training provided by the Veterans Administration. QPR, Question, Persuade, Refer. We have a number of members that are able to provide that, as well as Ask About Suicide to Save a Life. Ending the Silence programs for young people and adults from NAMI, and multiple trainings are available at the website stop1.info. We also have a number of resources at the Suicide Prevention Resource Center website. And have a number of resources that we'll make available on the website for you. As I mentioned, we have the suicide prevention hotline listed here, and the City of Mesquite provides free mental health services for any resident in Mesquite. And we're just so very fortunate to have that available. And that's through the Azar Foundation in conjunction with the city. If you need assistance with your students, you can contact the school district. Colleges have multiple resources. In Mesquite, we have the Multicultural Recovery Center, which is bilingual for English and Spanish speaking individuals. I mentioned our Rotary E-Club, which our Facebook page will be available in the next week or so, which has a lot of these resources listed, as well as we'll have these available on the website for the city. We have a number of courses that are through the Mesquite ISD Community Education Group. So if you go to the website, we have a number of classes available each month about different topics. The American Foundation for Suicide Prevention, Metrocare provides a number of classes. The UT Dallas Center for Brain Health focuses on brain health itself and has a great program available. The Halliburton Foundation, which focuses on young people. We have the VA North Texas information, as well as NAMI, the Veterans Resource Center. And there's actually an unusual number called the Friendship Line, which is specifically for people age 60 years and older. There's a lot of feelings of isolation and alienation for that age group. So if you just want to talk, you can call and talk. It's a 24-hour line, and it's available around the country. So I encourage you to call and talk to people. And if you are having some issues, they know who to refer you to for those issues. And we'll be making all of these things available on the Mesquite website.
Yes, we will make sure that I think they're already on there, and we'll make sure that we keep updating the list. So offer up any attendees that would like to ask a question. We've heard a lot of good information tonight. One of the questions in the chat already is, creating the conversation with children, and are there some programs out there that might help us and as parents to create these conversations early, to encourage kids to reach out and share what they might be experiencing? Shirley, do you want to take that one?
Yes, there is actually a program called Gizmo's Possum Guide to Mental Health, and it's specifically devised for elementary age students and through middle school, but it's free, it's online. You go to Gizmo for mental health, and we'll make that available also on the website. But it's a story about a little dog and his friends talking about their feelings and mental health, and it's something that children can do with their parents or with trusted adults. There's actually a little worksheet that talks about different types of feelings and what to do when you're feeling bad and ways to make you feel better and that sort of thing. It's a great program. There's a lot of resources available on the website with that program.
I'd also like to interject in there, and sometimes we need to part of the trainings that we do. So we have Talk Saves Lives, which goes through and tells you how to talk to certain people about that. There's the S word, which kind of tries to destigmatize the word suicide and get that out there. And a lot of it is just aimed at getting those people to go out and talk about these and ask those questions. I mean, if you're talking to a child, the possum is Gizmo, the possum dog is pretty awesome thing to talk about. But if they're older than that, then sometimes suicide as an adult is I can think of no other more adult decision to make than to take your own life. So at that point, we might need to talk to them specifically as a one person to one person, and talk to that teenager, that child, and find out what's going on. Don't try to belittle it or do anything else. Just acknowledge. You don't have to agree, but you can acknowledge that this is what they're feeling and that this is an actual choice for them. Now let's figure out how we can get that choice off the table. What's it going to take? Do I have to listen more? What do we have to do here? And once you begin that conversation, it'll be tough, but it normally will become a whole lot better. And there's also mental health first aid for young adults.
Or are there any questions that anybody would like to put into the chat? We'll give it just a second to see if there are any. I think each of us, as I've been, researching and looking into to mental health and and the awareness. What are if anybody wants to take this, what's been the most impactful? I mean, how did Shirley, we know your story, and so what brought y'all into this topic? And again, y'all are all great advocates for your different organizations. So how did you get started in this? Skylar, Domingo, either one.
Go ahead, Domingo, and I follow you.
Okay. So I had actually decided that I was going to take my life one day, and circumstances went down that road. I started drinking. It was 5 a.m. I started drinking, and somehow by the end of that day, I don't exactly remember the whole day, but somehow by the end of that day, I had received a phone call from an organization that told me they needed me to go, that I had signed up to volunteer, and we were going into a disaster area to go help people, and we were going to go do stuff like that. And it was amazing. It was an amazing organization called Team Rubicon, and they take veterans and put them together with emergency management, and they go into disaster areas and help special vulnerable populations. And so through that, I found my mission again. And 6 weeks later, when I realized that I hadn't taken my life, I decided that I needed to do something. But I couldn't keep going with Team Rubicon, volunteering, going out and employing. So I had to find local area organizations to volunteer with. And I just kept volunteering until I found the one that I couldn't stay away from, that I was actually, I had a business at the time, that I actually was putting aside business so that I could do my volunteer work. And eventually, I guess they just got tired of me being there and they hired me. So.
Wow. Skylar?
Oh, I was going to say, my mother was an educator, and even though I came from a large family, there were 8 of us, she still would reach out and help as many people as she could, and so I just saw her spirit, and that was something that encouraged me to go pursue being a social worker.
Sharon?
I mean, Domingo, I feel you. I lived with depression for a long time, and suicidal ideation was something I struggled with in high school. And I remember being super scared of telling my mom, like my mom finding out. It was the last thing you would think that somebody would be scared about, but shaming my mom and my family was the biggest thing. And I didn't realize that it was something that our culture experienced as a whole. And so when I learned that, I was like, oh man, I have so many things I want to tell parents. I have so many things I want to tell children about, just because I didn't have that language. I didn't have those tools. And so that's how I got into the mental health field.
Well, great. So, again, I think all of y'all are here for a purpose, and I appreciate your advocacy and your expertise tonight. And we'll, if it's okay, we're going to put your email contacts in the chat or for the recording, so people can at least reach out to you and if they need resources or if they just need some guidance. And I think one of the reasons why we've really focused on mental health this year is not because of the pandemic, and we've seen our citizens in Mesquite struggling. And one of the things that I found in my profession as a city manager is people put on a brave face, and so the people you interact with on a regular basis who might be struggling either financially, emotionally, family-wise, are out there, and you don't know until you have that opportunity to ask or provide an opportunity for somebody for outreach. And so, as an organization for the city of Mesquite, we are trying to create those avenues, not just for citizens, but for our employees. And we have some people in some stressful positions, and we want to make sure that they're comfortable talking about it, either through peer groups, through professional assistance, or just through our health programs. So I've known people who have struggled. And I've known people just recently who have experienced suicide in their family, and so it is a challenge that continues to affect people. So it's been, Shirley, I want to thank you for helping me on my journey, and the learning from your experience. And you start looking into things, and it's such a narrow topic. And once we started hearing what you have found, it was this wide area and there's just so much out there. So again, to the panelists tonight, thank you for your time. I know it's extra hours for everyone, but I know our people in our community and the people attending tonight, it means a lot to them. So appreciate all that y'all do, and for helping people in the community, and for tonight helping the people in Mesquite. So thank you. And to the attendees, we thank you for watching tonight. And if you have any suggestions or comments, feel free to reach out to us. And if there's another topic you'd like to hear, we're going to take a break for a few months, but we'll probably start back up at the beginning of next year with some other topics of interest. So again, thank you, everyone, and have a good evening.
Thank you. You
Thank you,
too.
Cliff.
Thank you.
Thank you.